Welcome, everyone, and thanks for joining. I'm Diane Weiser, SVP Corporate Affairs. We're pleased to be discussing new data presented this weekend at ESC, including the primary results from MAPLE-HCM, as well as other data related to aficamten. I'm joined today by my colleagues Robert Blum, President and CEO, Dr. Fady Malik, Executive Vice President of R&D, and Dr. Dan Jacoby, VP of Clinical Research. I'm also pleased to welcome our esteemed HCM experts. With us today are Dr. Pablo Garcia-Pavia, Head, Heart Failure and Inherited Cardiac Diseases Unit at the Department of Cardiology of Hospital Universitario Puerta de Hierro. Dr. Carolyn Ho, Medical Director of the Cardiovascular Genetics Center and Professor of Medicine at Harvard Medical School. Dr. Ahmed Masri, Cardiomyopathy Section Head and Director at the Hypertrophic Cardiomyopathy Center and Associate Professor of Medicine at Oregon Health and Science University. And Dr. Anjali Owens, Medical Director at the Center for Inherited Cardiac Disease, Director of the Hypertrophic Cardiomyopathy Center, and Associate Professor of Medicine at the University of Pennsylvania. Thank you all for being here today. Moving to our agenda, first, Dr. Fady Malik will provide introductory comments. Next, Dr. Pablo Garcia-Pavia will provide an encore presentation of his hotline of MAPLE-HCM results from the conference. Then, Drs. Malik and Jacoby will lead a discussion with Drs. Garcia-Pavia, Ho, Masri, and Owens to provide perspective on the data and answer questions. And finally, Robert will provide some closing remarks. To submit a question during the panel discussion, please type your question into the box in the tab on the right titled Ask a Question. Please note that portions of the following discussion, including our responses to questions, contain statements that relate to future events and performance rather than historical facts and constitute forward-looking statements. Our actual results might differ materially from those projected in these forward-looking statements. Additional information concerning factors that could cause our actual results to differ materially from those in these forward-looking statements is contained in our SEC filings. In addition, on today's call, Drs. Garcia-Pavia, Ho, Masri, and Owens will share their professional perspectives on the clinical significance and safety implications of aficamten-related data presented at ESC. These perspectives are solely the opinions of Drs. Garcia-Pavia, Ho, Masri, and Owens, and may not reflect the opinions of Cytokinetics or other experts who review these data, including those who will review the NDA for aficamten at FDA and applications submitted to other regulatory authorities. Drs. Garcia-Pavia, Ho, Masri, and Owens are here today as contracted consultants with Cytokinetics. And now I will turn the call over to Fady.
Thanks, Diane. Over the weekend, we were proud to present 4 oral presentations and 1 poster related to aficamten, accompanied by 3 simultaneous publications in leading cardiac journals. The depth and breadth of these data add substantially to the existing body of evidence supporting the potential of aficamten as a treatment for obstructive hypertrophic cardiomyopathy. To start off, on Saturday, Dr. Garcia-Pavia presented the primary results from MAPLE-HCM, the Phase 3 active comparator clinical trial comparing aficamten to the standard of care beta blocker metoprolol in patients with oHCM, which was also published in the New England Journal of Medicine. This study is truly the first of its kind, providing both a direct look at the treatment effect and safety of treatment with a cardiac myosin inhibitor versus a beta blocker, and a look at the efficacy, safety, and tolerability of metoprolol itself in oHCM. The results in showing the superiority of aficamten to metoprolol challenge the rationale for the long-standing first-line approach of treating HCM with beta blockers. As Dr. Garcia-Pavia will elaborate, while aficamten improved exercise capacity, metoprolol resulted in a meaningful reduction in exercise capacity. Treatment with aficamten also produced larger improvements in symptoms, gradients, and cardiac biomarkers as compared to metoprolol, with a similar rate of adverse events. Additionally, Dr. Sheila Hegde from the UT Southwestern Medical Center and Brigham and Women's Hospital presented a pre-specified analysis of the echocardiographic data from MAPLE-HCM. The analysis showed aficamten had a larger impact than metoprolol on measures of cardiac structure and function, improved measures of diastolic function, and reduced key contributors to left ventricular outflow tract obstruction. These results were accompanied by a publication in the Journal of the American College of Cardiology. Beyond MAPLE-HCM, in a late-breaking clinical science section, Dr. Masri presented an analysis showing that in FOREST-HCM, the risk of atrial fibrillation was quite low during long-term treatment with aficamten and consistent with expectations from validated prediction models of atrial fibrillation. In those that did develop atrial fibrillation, it did not negatively impact clinical status. These data were published in Heart Rhythm. Given atrial fibrillation is an emerging topic of conversation around the use of cardiac myosin inhibitors, these data suggest long-term treatment with aficamten does not appear to increase the risk of atrial fibrillation in OHCM. Dr. Sarah Saberi from the University of Michigan also presented longer-term data from FOREST-HCM with a mean follow-up duration of 62 weeks and a maximum follow-up duration of over 3 years. As you've seen previously from FOREST-HCM, these data again show that aficamten is associated with early and sustained hemodynamic clinical benefits, along with a low incidence of new-onset atrial fibrillation and LVEF less than 50%. Adding further to these findings from our updated integrated safety analysis presented by Dr. Masri, builds on the first integrated safety analysis we presented last year, inclusive of Redwood-HCM, Sequoia-HCM, and FOREST-HCM, now including MAPLE-HCM as well. Combining 463 patients and almost 700 patient years of experience, aficamten was shown to be well tolerated with a low incidence of LVEF less than 50% and no occurrences associated with serious events of heart failure. All in, these data expand the evidence base for aficamten and deepen our understanding of its potential application in OHCM. Now I'll hand it over to Dr. Garcia-Pavia to present the results of MAPLE-HCM.
Thank you very much. So it's my pleasure to present the data of the MAPLE-HCM that were presented last Saturday in the late-breaking trial session of the European Society of Cardiology meeting. Next. So, on behalf of my co-authors, again, I present this data of the trial MAPLE-HCM. Next. Here you can see my disclosures. So, obstructive HCM is a disease characterized by hypercontractile left ventricle hypertrophy and left ventricular outflow tract obstruction, resulting in limited symptoms and reduced exercise capacity. Aficamten is a next-in-class cardiac myosin inhibitor that targets the underlying pathophysiology of HCM by reducing hypercontractility. Aficamten has demonstrated already several benefits in patients with obstructive HCM who are symptomatic despite the standard of care therapies. In this study, currently the most common standard of care therapy used in clinical practice is beta blockers. And beta blockers have been the first-line treatment for symptomatic patients with obstructive HCM for more than 60 years, despite very limited evidence. In fact, beta blockers are recommended both by the European and American guidelines with a class 1 level of recommendation as the first-line therapy of choice in patients with symptomatic obstructive HCM. Next. In MAPLE-HCM, we sought to evaluate the safety and efficacy of aficamten in monotherapy compared with one of the most commonly used beta blockers in these patients, which is metoprolol in monotherapy. So unlike the previous studies, we are not adding aficamten to a standard of care medication. Here we are comparing aficamten with the standard of care medication. The primary endpoint of the study was exercise capacity assessed through peak VO2, which is a parameter that is captured in cardiopulmonary exercise test. Secondary endpoints include symptoms, Valsalva left ventricular outflow tract gradient, so the degree of obstruction under Valsalva, NT-proBNP, which is an accepted biomarker of heart failure, and certain echocardiographic parameters like left atrial volume index and left ventricular mass index. In this slide, you can see the design of the MAPLE-HCM study. We randomized 175 patients to receive either metoprolol plus placebo or aficamten plus placebo and followed them during 24 weeks. During the initial 6 weeks, both investigational products were dose adjusted based on site echocardiogram parameters and vital signs. Both patients with recently diagnosed or treatment-naive obstructive HCM and patients with chronic obstructive HCM on standard of care medications could participate in the trial. If the patients were already taking standard of care medications, they had to undergo a 2-week washout period of standard of care medications before undertaking the screening visit were qualified for the study. Here you can see the baseline characteristics of the participants in the study. Overall, patients had milder phenotype than those patients previously included in previous CMI studies. The median NT-proBNP of patients participating in the study was around 500 picograms per ml. The mean peak VO2 value was around 20 mL per kilo per minute. And regarding gradients, LVOT gradient at rest or with Valsalva were around 45 millimeters of mercury and 75 millimeters of mercury, respectively. Of note, we observed that there were more patients with hypertension in the aficamten group than in the metoprolol group. During the trial, the majority of patients were exposed to the highest doses of metoprolol and aficamten, as you can see here on the slide. And at week 24, we found that 10 patients who were receiving metoprolol did not tolerate any dose of this drug, as compared to 1 patient on the aficamten group. At week 24, patients receiving metoprolol exhibited a mean decrease of 6 beats per minute in resting heart rate and a mean decrease of 6 millimeters of mercury in systolic blood pressure, as compared to a mean decrease of blood pressure of 5 millimeters of mercury in the aficamten group and no change in heart rate at rest. And here is the slide where we presented the results, the primary endpoint results. After 24 weeks of therapy among patients receiving metoprolol, we observed a mean decrease in peak VO2 of 1.2 mL per kilo per minute, while in patients receiving aficamten, we observed a mean increase in peak VO2 of 1.1 mL per kilo per minute. The absolute least square mean difference of aficamten compared to metoprolol was 2.3 mL per kilo per minute, which was statistically significant with a p-value of less than 0.001. This difference is way above the minimum threshold of clinical significance in clinical practice, which is considered 1 mL per kilo per minute. Next. When analyzing the pre-specified subgroups regarding the primary endpoint, we observed no heterogeneity, including for the diagnostic period of the disease in patients participating in the study. Regarding secondary endpoints, both improvement in NYHA class, change in KCCQ, which is a parameter of quality of life, change in NT-proBNP, Valsalva LVOT gradient, and left atrial volume index were all statistically significant in favor of aficamten, while the change in left ventricular mass index was not statistically significant. Analyzing deeper the parameters of the secondary endpoints, and here you can see the functional class, we observed that at week 24, 51% of patients treated with aficamten and 26% of patients treated with metoprolol had one or more improvements in NYHA classes. Of note, at week 24, 40% of patients receiving aficamten were asymptomatic in NYHA class 1, while in the metoprolol group, this percentage of patients who were asymptomatic was only 9%. Regarding KCCQ, a parameter of quality of life, we observed that among patients who received metoprolol, they did improve in this parameter, but the improvement observed in patients receiving aficamten was larger, with a less square mean difference between groups at week 24 of 7 points, again statistically significant. Surprisingly, during the trial, we observed that metoprolol did not improve resting LVOT gradient or Valsalva LVOT gradient, which is the obstruction that these patients suffer when a systolic ejection of blood from the blood. In contrast, patients receiving aficamten had a sustained and early decrease in obstruction as observed in the graphs, with a mean LVOT gradient at the end of the trial, in both cases for rest and Valsalva gradients below the accepted thresholds in clinical practice that are shown here in the graphs in dotted lines. Next. Regarding change in NT-proBNP and left atrial volume index, which are two parameters of diastolic dysfunction, we observed that those patients who received metoprolol, these parameters increase during the trial, while these parameters decrease in the group of patients receiving aficamten. Of note, by the end of the trial, NT-proBNP values in the aficamten group were at the upper limit of normality, as you can see here in the graph, with an 81% reduction compared to baseline. Regarding safety, aficamten was well tolerated. 3 patients had to stop metoprolol during the trial due to adverse event, as compared to 1 patient on aficamten. A total of 26 patients had to reduce the dose of metoprolol during the trial, compared to 4 patients on aficamten. Consistent with the mode of action of aficamten, at week 24, we observed a mean decrease in left ventricular ejection fraction in the aficamten group of 5.3%, compared to a decrease of 0.5% in the metoprolol group. But only 1 patient in the aficamten group had a left ventricular ejection fraction below 50%, as assessed by the core lab, and this patient did not have any heart failure symptom or sign, and actually, the left ventricular ejection fraction reduction got resolved without stopping aficamten, just by decreasing the dose. Next. So in conclusion, the results of the MAPLE-HCM study show that aficamten in monotherapy was superior to metoprolol in monotherapy in patients with symptomatic obstructive HCM, with statistically significant and clinically meaningful improvements in exercise capacity, symptoms, Valsalva LVOT gradients, NT-proBNP, and left atrial volume index. Despite we have been using metoprolol for more than 50 years to treat patients with obstructive HCM as the first-line therapy, and there was a strong evidence of on-target hemodynamic effects with metoprolol both in heart rate and systolic blood pressure, we did not observe a decrease in obstruction at rest or with Valsalva in participants receiving metoprolol in this trial. Aficamten treatment was well tolerated, and overall, we consider that these findings support aficamten monotherapy as the first-line therapy of choice in patients with symptomatic obstructive HCM. Next. We want to thank all people who have made this trial possible, and particularly participants and their families. Next. The results of this trial were published simultaneously on Saturday at the New England Journal of Medicine. Thank you very much.
Thanks, Pablo. To dive deeper, I'd like to shift now to our panel discussion. I'm pleased to be joined by my colleague, Dr. Dan Jacoby, and alongside Pablo, we also welcome Dr. Carolyn Ho, Dr. Ahmed Masri, and Dr. Anjali Owens. I'd like to start by discussing the results of MAPLE-HCM, including the primary results and the echocardiographic analysis on the effect of aficamten compared to metoprolol on cardiac structure and function. But first, Pablo, it was quite an exciting weekend. Obviously, lots of over 30,000 people attending the ESC and several thousand of them in the presentation hall where you gave this presentation. Can you just give us your perspective on the impact of the results from MAPLE-HCM, and then perhaps comment on the reactions to your presentation at the Congress?
Thank you, Fadi. Yeah, the presentation was a great success. We have been using a drug that for more than 50 years that actually had very limited evidence to support its use in this disease. And this trial not only brings a new drug to treat these individuals as first-line therapy and immunotherapy, but also provides the data to conclude that the existing therapy that we were using and which is prescribed massively, I would say, has limited efficacy in these patients, and potentially, even with some of the parameters that we have shown, it could deteriorate these individuals. So therefore, this is certainly a game changer, as stated by the moderators of the session, and the excitement that I saw in all the people who came to the Congress based on these results was massive. It really will help us in having a better drug in order to improve our patients and with very limited side effects as shown in the study. So really, I was delighted to present this data in my hometown of Madrid, and everybody stated that this was one of the most important presentations of the Congress. Actually the most important Congress that there is in the world based on the number of people attending the Congress, which was around 35,000.
Thanks, Pablo. I'm sure it was truly a special experience for you and doing this in your hometown. And for many of us at Cytokinetics that were there at all to witness it. Also participating in that Highline session was Dr. Ho, who was a discussant of your presentation. And Carolyn, do you want to perhaps just summarize what your comments were and also maybe add to Pablo's perspective?
Yeah, absolutely. And I would just like to build on Pablo's comment about the importance of this trial, mainly in showing us that what we had assumed to be the standard of care approach to symptomatic obstructive hypertrophic cardiomyopathy was not nearly as good as we thought it was, and that really highlights the importance of doing proper randomized clinical trials to guide our clinical management. And I think that what people were most shocked by at the Congress was just how poorly beta blockers perform in this population. So this is, again, the treatment that we had long assumed for decades to be the way to go to try to help improve symptoms, and our patients are just being shown with objective evidence that they really don't achieve any of the objectives that we were hoping they would in terms of gradient reduction, symptom improvement, or improvement in functional capacity was really very revelatory, I would say.
It's great. Yeah, it I suspect did shake people's presumptions about the treatment that they were using for so long, and I even heard in some cases people questioning what they would do when they would go back to their patients that are continuing to take beta blockers. But maybe I can ask also Dr. Masri to comment. You gave several presentations at the Congress, and obviously you probably also interacted with many of the attendees. Dr. Masri, do you want to give your perspective as well?
Definitely. Congratulations to everyone here on the call and to really our patients, because, we delivered on something that really has been in a way entrenched in the practice. And, we've observed a long time ago that once you go, on beta blockers and whatnot, it's not necessarily what everyone believes it to be. So great to have very proper randomized clinical trial data to support that. Aficamten performed as we've expected to. Correct. We've had now accrued so much data and evidence behind aficamten. I think really the highlight of MAPLE is the fact that metoprolol did not just not do what we wanted it to do, which is affect hemodynamics to improve symptoms and quality of life in a meaningful way beyond what we expect from placebo, but also worsened exercise capacity, which is important for long-term outcomes as well, worsened measures of wall stress, diastolic function, such as NT-proBNP and left atrial volume index. And so these things for me are really important, because the principle is always, for us, is we want to help patients and not harm anyone. Those are the principles. And harm doesn't have to actually be that you are leading to an adverse event that you can visually see in front of you. It can also be that, you are reducing their exercise tolerance and their ability to do more, aside from the side effects. Now, for the longer term data, which I'm sure we'll discuss later on, what's important from my perspective is that when you use a hemodynamic modulator with a myosin inhibitor, it is really meant not to only focus on the initial duration of the randomized clinical trial. The randomized clinical trial establishes the efficacy and the short-term safety, but the long-term data are so vital for us, especially as a drug like aficamten progresses, hopefully in the next few months to early next year to the commercial stages, that you want to make sure that over a long period of time, this drug performs from an efficacy and safety perspective as you would want it to.
Okay, great. Thanks, Dr. Mazur. I think, we got several questions from our people online as well as prior to this call. Let's go through them perhaps, and then I'll get people's opinions on this. So, first question is, the level of peak VO2 improvement in MAPLE was 1.1 for aficamten, which was slight, as a change from baseline for the aficamten treatment group, which was lower than that of 1.74 that we observed in Sequoia. And so the question really is, what do you think contribute to the lower absolute treatment effect for aficamten relative to baseline, and whether, can you make this sort of cross-trial comparison? So Dr. Pablo, you want to?
Yeah, I will address that one. Yeah, the population of patients included in the study in both studies were completely different. These patients included in the trial were milder, in the sense that these were patients who had better exercise capacity at rest. So if you are starting in a higher point, it's more difficult to go higher than if you
populations. One of our questions here is what's the rationale behind including less severe patients in MAPLE as to Sequoia? Maybe I'll take that because as we designed the study, when we designed Sequoia, really we're focused on treatment failures, patients who had still very high gradients, resting gradients, symptoms, despite being treated sometimes with even up to 3 different medical therapies. And in this case, we wanted to expand the population to really understand the treatment effect of aficamten in all comers, anyone who met the criteria for obstructive HCM, which is a gradient, either Valsalva gradient 50 or a resting gradient greater than 30. In Sequoia, that was an and. Patients had to have both. They had to have worse exercise performance and other things at baseline. And so, this we thought would apply more generally to clinical practice, and the effects would be more generally applicable to what people see as patients come in.
Adi, can I say also that
Please.
Given say that the degree of improvement was less than the one shown in Sequoia, it was still above the minimum threshold difference considering clinical practice, which is 1 mL per kilo per minute. And we know from retrospective studies that were published that if you increase as the increase of peak VO2 goes more than 1 mL per kilo per minute, the risk of death and heart transplantation gets reduced more than 21%. So I think it's fair to say that was less, but it still was significant.
Yeah, no, absolutely. Why don't we go to the next question? And the next question, maybe I'll throw to Dr. Jacoby because he's most familiar with these details. It has to do with 3 patients on aficamten were down titrated due to LVEF less than 50. Did this happen at the maximum dose? Dr. Jacoby, you want to take that one?
Yeah, sure. Yeah, the doses were a range of the upper doses for those patients, and the down titrations occurred at different points in the study. There wasn't any real pattern to it. And it was not, just at the highest dose that a down titration occurred. So, which is not completely unexpected. It's what we've seen, across our studies. These are individually titrated doses based on echocardiography for that individual patient. And so, although there is some relationship between dose and effect, it's not surprising that you would see a range of doses. But these did not occur at the lowest doses, which is important. The lowest doses remain safe without any real incidents of LVF excursions in those groups.
Great, thanks. This is an interesting one. So on safety, the most common adverse event reported was hypertension for aficamten. Is this something that needs to be monitored or treated, and how is this different than what was seen in Sequoia? Maybe Dr. Masri, I'll ask you to take this one because I know we've discussed this many times.
Yeah, this is a long-term experience with the relief of LVOT obstruction. You're improving cardiac stroke volume and cardiac output, and when you are relieving LVOT obstruction, you're essentially unmasking. These patients have arterial stiffness and other arterial issues that contribute, and so you're just making them feel better, improving their stroke volume, cardiac output, and that's why you see this blood pressure rise, and it can usually be easy treated. This is not really, in a way, thinking of it as an adverse event that the drug actually raises blood pressure, because we've seen that across the board from other myosin inhibitors, and we see this also in our experience after you relieve LVOT gradient using other methods and metrics as well.
It's really kind of unmasking an underlying condition that exists pre-existing. Our next question is that given that beta blockers seem to be making patients worse in some aspects, do you think the evidence is strong enough to warrant skipping them as first-line option altogether and using aficamten up front? And maybe, Dr. Owens, I'll ask you to comment on that question.
Sure, happy to comment. I think that what MAPLE showed us is that using a targeted therapy that addresses the underlying pathophysiology of a disease works better than a nonspecific therapy that was used because, quite frankly, it was the best that we had. And so I think certainly moving towards treating a disease with a targeted therapy is where we're headed. And I absolutely think that this data supports starting a CMI early, if not first. There are other things that we have to take into consideration when we treat large volumes of patients, including access to therapy, of course, cost of new therapies. So there are other things in the real world that we have to take into account. But I 100% think that this tells us, beyond a doubt, move to a targeted therapy when you have one.
I think also, there was probably a little confusion maybe about the message in terms of the use of beta blockers in this condition. And we have a question, is there a role left for beta blockers in treating OHCM? And maybe Dr. Ho, I'll ask you to comment on that because I think you did address that in your discussion.
Yes, absolutely. So it's tricky, right? Because as Anjali said, it's not just about, taking the therapies in isolation. We have to consider access, costs, ease of implementation, and all of that. And also, the MAPLE trial was designed to take people that weren't feeling well on beta blockers, so it was a little bit selected in that way. So I think that it's possible that there are some people with very mild manifestations of HCM and mild symptoms that it may be practically easiest to initiate beta blockers first and see how they do on that. And that might be the niche for beta blockers. And beta blockers are also very helpful in treating other issues related to hypertrophic cardiomyopathy, like atrial arrhythmias or ventricular activity. So I think that they will continue to play a role in the management of our patients along those regards. But certainly a more targeted therapy like a cardiac myosin inhibitor is far more effective in terms of treating the more pronounced manifestations of disease, and specifically outflow tract obstruction and the issues related to outflow tract obstruction.
Pablo, do you want to add to that?
Yeah, and I think that I think the data really support aficamten as first-line therapy, monotherapy in this patient. So what this data are going to do is that they're going to change the order that we use these medications. In the trial, obviously, people who go into a trial is because of a reason, and there was a group of patients who probably were symptomatic already on beta blockers. They stopped the medication and then went into the trial and received either beta blocker or aficamten. But there was still a 30% of newcomers that were not on therapy before, were not taking beta blockers before going into the trial. And we observed exactly the same and analyzed the first line patient. Moreover, we also undertook an analysis based on what was the dose of beta blockers that were taken in order to see if that had made any contribution to the results, and no interaction with beta blocker dose was found. Moreover, you could say, well, maybe only patients who were intolerant to beta blockers or who had side effects due to beta blockers went into this study. But that was not possible because there was a clear exclusion criteria to participate in the study, which was intolerance or side effects due to previous beta blocker exposure, because we didn't want to have somebody into the trial who maybe would have received beta blocker in the trial. So really, really solid data here. Moreover, even if we excluded the 10 patients who actually did not tolerate the beta blockers, we got exactly the same results.
Great. Thanks, Pablo. Amy, lastly, Ahmed, I know you addressed this question in one of your talks, but do you want to also perhaps briefly comment? I think it's a really important point.
Definitely. I think ultimately, you have phase 3 randomized clinical trial data. Again, this wasn't an easy trial. Kudos to all of you and us for actually our patients for doing this. But really, it wasn't an easy trial and it wasn't been very, conducted very well. Now, the question is, do you now use beta blockers widely as a first-line therapy in obstructive hypertrophic cardiomyopathy or what? And the takeaway for me from this is that, it becomes on a case-by-case basis. If you have reasons to go for it, you have reasons to go for it. But, the big elephant in the room is that, we need, aficamten to be available as well to be able to use it as a first-line therapy and monotherapy for these patients. So that's ultimately the goal here. But the beta blockers would be, in my opinion, case-by-case basis going forward.
Great. Thanks, everybody. In the interest of time, I want to move on to a couple of the other presentations that were made, and maybe I'll turn it over to Dr. Jacoby to introduce the next topic. Oh.
Hello, can you hear me?
Yeah.
Yes, thanks very much. Yeah, hi. So we received a number of questions about the results of Odyssey, actually. And this was presented over the weekend by VMS. And the questions here are HCM, Acacia HCM. Obviously, we've excluded questions that compare aficamten to other compounds for obvious reasons. But I guess I want to start off really by asking Ahmed's fallen off here, but I guess I want to ask Carolyn in that case, why do you think Odyssey didn't hit its primary endpoint over here? Do you have a perspective on that? And then as a correlate to that, I guess can you opine on any particular aspects of the forest plot or the subgroup analysis that might, provide any insights there?
Yeah, well, I guess that's $1 million question, and so much to think about. But Odyssey was, really important in being the first, quite large scale testing of a cardiac myosin inhibitor for symptomatic non-obstructive HCM, and we're learning, as they go along. And I think that one of the big things that stood out to me is that non-obstructive HCM is relatively straightforward. We have a good target to go for in terms of drug titration, and improving and resolving obstruction really is associated with clinical improvements, symptomatic improvements, improvement in feel and function. Non-obstructive HCM is much more complex and heterogeneous, and so it may be that a one-size-fits-all approach doesn't work for non-obstructive HCM as it does for obstructive HCM. We fundamentally don't know really what the mechanism underlying symptoms are in non-obstructive HCM. We believe that they're largely driven by diastolic abnormalities and inefficient myocardial energetics, which may be improved by cardiac myosin inhibitors. But I think trying to think about what dose is needed is important. And it's difficult with non-obstructive HCM because we don't have a clear biologic target to give us minute-by-minute readout as to whether we're giving the right dose. With obstructive HCM, we're able to target the minimal effective dose, but once we've relieved obstruction, we can stop dose of titration. But with non-obstructive HCM, we want to guard against underdosing, particularly in the realm of clinical trials, and so we're really going for the maximum tolerated dose, up titrating as long as LVEF seems to be still tolerating. And so I think, a lot to learn. Odyssey was relatively close statistically to hitting significance both in peak VO2 and KCCQ. So, I think there's still potential for CMIs to be beneficial in non-obstructive HCM, and we'll just need to await further information as it comes through.
Yeah, thanks, Carolyn. And what I hear you pointing out here is that you really need the kind of drug that can have a therapeutic window between efficacy and toxicity that's broad enough to be able to titrate the dose there. Pablo, do you have any thoughts, or did you hear anything in terms of discussions at ESC on this topic?
Well, obviously it was a big disappointment because for obstructive HCM, we thought we had some therapies, but for non-obstructive HCM, or at least we still have myectomy and surgical procedures, but for non-obstructive HCM, we did not have anything. So the disappointment was big. And particularly, there was concern about the number of individuals who had to stop the medication during the trial, the Odyssey trial, because that certainly could have had some impact in the results. Because if you have to stop the medication and then wait 4 weeks to restart the medication and so on at a lower dose, that could have had some impact in the outcomes of the study. We need to see that aficamten in the following study in the Acacia, because of the pharmacological properties that the compound has and the design of the trial, which requires, in case that the ventricular ejection fraction dysfunction appears, the drug is not stopped, it's reduced. Maybe in those cases that is critical in order to achieve a good evolution of these patients. We will see what happens.
Thanks.
Pablo, maybe I could just ask one question if I can just jump in. You were the second largest enroller in Odyssey, and so you had I think you enrolled 20 patients. So what was your, impression?
Patients who did very well. I can say that. There were certain patients who really improved largely during the trial. And actually, by looking the data in the study and some of the sub-analyses that have been presented during the ESC, the NT-proBNP values and the echocardiographic parameters, there are in the mavacamten group. So I still think that CMIs can have a role in non-obstructive HCM, because there are certain parameters that really improve largely, as we have seen in clinical practice, among the patients included in the trial. So let's see. I think we have more hope. It was. I don't think this is ended. I think Louis is out, and looking forward to know what happens.
Yeah, just to quickly build on that, I totally agree with Pablo. Again, the population that we're working with in non-obstructive HCM, I think we're learning is much more heterogeneous, and there might be sub-cohorts within the overall population that benefit from chronic myosin inhibitors that are really hyperdynamic. This is an obstruction, so maybe we just have to see where that's going to take.
So just to follow up to that, for Anjali, there's two things. One is, I think people were a little bit surprised by the amount of placebo effect seen in the KCCQ in this study, and I'm sure you don't have an answer for that. Do you have any perspective? And I guess, tangentially, but similarly, if you have any insights from what you've seen in the literature that's been published from force support any read-through perspective on whether Acacia might be different, specifically along the lines of what Carolyn and Pablo were just talking about.
That's a great question. I wish I had the answer to the KCCQ improvement in the placebo arm. It's hard to know exactly why we saw that 10-point improvement, where in prior studies, including the phase 2 Maverick, we saw more in line of 6-point improvement. I think it's different to do randomized controlled trials in this population where we do see a significant placebo effect. Keep in mind, these patients were in close contact and care with their physicians for the 48-week trial period, which they assessed as these patients were getting more intensive care, more recognition, potentially of periods of congestion or periods of AFib, and they were being actively managed. There's always the question of background therapy that's being given for other comorbidities that are quite common in patients with non-obstructive HCM, including obesity, and the rise in use of GLP-1s, of SGLT2 inhibitors. I think, that could have potentially played a role. We have to do a deeper dive, as Carolyn and Pablo have said, into the responders. I think the therapeutic hypothesis of myosin inhibition in non-obstructive HCM is still very much alive based on the signals that we saw in biomarkers and in evidence of diastolic improvement and structural improvement. So as we said, it is certainly not one size fits all in non-obstructive HCM, and it's probably not even one size fits most. You really have to do an individual analysis of where your patient is on the continuum of disease, and it may be that myosin inhibition benefits some and not others. What we've seen in terms of the long-term data in FOREST, I think, is very good, and it speaks to the fact that hopefully we'll get a positive result in ACACIA. But I think non-obstructive HCM in general is a higher risk proposition than obstructive HCM, and we have to be realistic about that. And think about really understanding the underlying disease pathophysiology in the non-obstructed state where we don't have the biomarker of obstruction, and how we might benefit those patients in the long run. With regard to the subgroup analysis that you had asked Carolyn, and she started to mention, we did see some signals for the patients who were perhaps younger and perhaps less sick, the class 2 patients. So there's a possibility that we enriched too much for those that had advanced diastolic dysfunction, and subsequently probably longer duration of disease in Odyssey. So all these things will need to be looked into.
Thanks, Ashley. I want to pass it over to Dr. Malik here for a question and then a follow-up.
Sure. I first of all, would just like to ask Pablo maybe a question with regards to aficamten. We have ACACIA ongoing. What property? We've just finished MAPLE, so you're pretty familiar with what the properties of aficamten are. What properties of aficamten do you think may enable it to succeed in NHCM?
Well, I think the wide therapeutic window that it has is certainly something very positive because it allows us to modify the dose quickly, and that really is helpful because when you have one of these patients, what you want is to uptitrate as soon as possible so they start improving. You don't want to keep the patients under your care several months until you can increase the doses. So that's one of the things. Second, I think it's important the absence of relevant drug-to-drug interactions. So I think that's very helpful in everyday clinical practice. So those two things are really, really key when selecting the drug that you want to use. And those are mostly the things that you really, really want in a drug that you are using in clinical practice. And also that it has a good efficacy, obviously. That's safety and efficacy. And so far, they have been excellent in the trials that they have been conducted so far with AFI.
Yeah, I agree. I mean, I think obviously what we saw in Odyssey, I think, was evidence that the underlying impact on measures of diastolic function improved, biomarkers improved. You saw trends in the endpoints that were positive, but perhaps the measures of efficacy clinical efficacy were confounded by some of the challenges with obtaining the proper dosing and treatment interruptions and things like that, as the panelists pointed out. Let's move back perhaps to MAPLE quickly, and before we wrap up, there was an impactful presentation, an impactful study. How do you think the process and timing for updating guidelines is for something like this, and what might you expect or guess? I guess I shouldn't say expect because who knows how the guideline committees will land, but what would you guess if it were you in their shoes?
Well, I can speak by the European Society of Cardiology guidelines. During this Congress, it has been announced that there's going to be a focused update of the 2023 cardiomyopathy guidelines, and that's going to take place and be published in 2027. So I guess that will allow plenty of time to know what do regulators and payers also, if they approve or not AFI for the indications that they have already been filled, and maybe in the future there will be others. And certainly the guideline committee will have to take into consideration the results of MAPLE and ACACIA in order to incorporate them into the update of the guidelines.
Okay. Carolyn, do you want to add to that?
Sure. The American Guidelines Committee haven't met yet about informally to discuss this. It's never a fast process to update guidelines. The U.S. guidelines have moved to what will hopefully be a more nimble and kind of rapid processing of guideline updates, so you're not waiting years and years between guideline versions. But even with the more rapid strategy, it took almost 2 years for the update and the HCM guidelines to come out. So I suspect that there would be a pause waiting for ACACIA to read out, and thereby being able to handle non-obstructive HCM and the role of beta blockers at the same time. So probably kind of targeting the same date in 2027 to perhaps have a more full guidelines.
Great. Well, thanks. I want to really thank our panelists for joining us today. Dr. Masri had to leave early for clinic. Thank you all. And I want to turn it over to Robert Blum, our CEO.
Thank you, Fady. And thank you also to Drs. Garcia-Pavia, Ho, Masri, and Owens for joining us on this call today. We're especially pleased by the positive feedback that we're receiving from cardiologists related to the results of MAPLE-HCM, as well as the additional data coming out of ESC relating to aficamten in oHCM. Having 3 more high-profile and simultaneous publications further reinforces the importance of a growing body of evidence that we believe underscores momentum building within the field and around aficamten and its potential role in oHCM. However, in the meantime, we continue to work with FDA as it reviews the NDA for aficamten with the PDUFA date in late December. Also, please understand the NDA was accepted based on efficacy and safety results of SEQUOIA-HCM, our first phase 3 trial of aficamten. Preparing with the regulatory report for MAPLE-HCM, and we expect to submit a supplemental NDA to include trial results into labeling following the potential approval of aficamten later this year. We also look forward to sharing top-line results from ACACIA-HCM in the first half of 2026 and the primary results at a medical meeting hopefully soon to follow. We very much appreciate your interest in Cytokinetics and our development program for aficamten. We're looking forward to keeping you up to date on our progress, and thank you for joining on our call today. Operator, with that, we can bring it to a close, please.